Okay, team. It's time for us to get started. Who had a good morning? Yeah, what a morning it was. We did get closed down a little bit earlier than we hoped. A few people, including Bill and I, did get stranded on the other side, but hopefully got a little private ski-mobile sort of tour, which is a bit fun. Exciting news. Looks like we're going to get about 30 centimetres tonight. So, and that's not me just doing what I usually do and talking things up. It's actually the snow report that says that. And generally that snow report, when it says about 2 centimetres, it's 20 centimetres. So, not meaning to talk it up, but it's going to be good tomorrow. And even better news, the wind's going to be dropping, and Friday we might see some sunshine. So we've got everything this week, so get excited. Early bedtime tonight is the hot tip. 3 presentations we've got. So we are going to sort of move through things quite quickly this evening. It means that we won't have too much of a break between our first 2 presentations. So if you do need to get up, stretch the legs, fill up your glasses, hit the toilet, whatever you need to do, please feel free to do that as we go. We will have about a 10-minute break between presentation 2 and 3 though. So just a bit of a heads up on the running there. For those who haven't registered yet, just during the break, if you're right to see us at the registration table just out the front, and we'll make sure that you guys get your lanyards. That's it for me for now. So let's give a nice warm welcome to our first presenter of the evening, Professor Robyn Williams. Thank you, Robyn.
Thank you. Thank you, Quentin. Thank you to Quentin and Dylan for giving me 25 minutes to tell you a little bit about a project that we're doing in Western Sydney. So before I start, because this is sort of centred around the Australian healthcare system, is there anyone in the audience who is not from Australia or New Zealand? A couple of people, okay. If you are from Europe or Japan or any other places, US maybe, our system is probably a little different to the system that you're used to. Our system is a public healthcare system combined with a private system, and the emergency departments that I'm talking about today are in a public healthcare system. So they're a government-funded system, and they're open to anyone who comes to the door essentially for their care. So what I want to talk to you about is how to improve ED patient experiences and outcomes for patients from vulnerable cohorts. So it's a project that's been running for 5 years, and we're looking at people who normally don't do so well in the emergency department. So these are older adults, so nominally people aged over 65, but really what we're talking about are those older adults who are perhaps more frail. They might be on an aged care package either in their home, or they might be resident of an aged care facility. People with a disability, both cognitive type disabilities and physical disabilities. People who present to the ED with a mental health condition. Aboriginal and Torres Strait Islander peoples who don't do very well either, and people from culturally and linguistically diverse backgrounds. And in the area where we're working in Western Sydney, 47% of the people are from culturally and linguistically diverse backgrounds. So that means that they either speak a language other than English at home, or English is not their first language. So the project itself is running in 3 emergency departments in Western Sydney. So that's Westmead, which is a tertiary care facility, Blacktown, which is a major hospital, and Mount Druitt, which is a district hospital. And these hospitals are all linked, and often patients will present at Mount Druitt but end up at Blacktown or Westmead, depending on the acuity of their injury. So the project itself is a multi-phase project where initially we went in there with the team, and I'll present the team right at the end, but there's 10 of us all up. We went in there and did ED observations for around a month, just looking to sort of understand how the ED works. And it's quite important because if you just talk to people about how it works, they give you their perception, but often how it actually works can be quite different to the way they're perceiving it. We then interviewed around 50 ED doctors and nurses and a couple of clerical staff that worked in each of the 3 EDs. And we interviewed clinicians who were also treating people from those vulnerable cohorts. So we interviewed the hospital psychiatrists who were still working in the hospital at that point. We interviewed people, we interviewed geriatricians, we interviewed other people who looked after those people. And then we interviewed the people themselves, so the patients that were part of that cohort. So up to 50 from each of those cohorts. And we included carers or family members as well. Some of them like to be accompanied by a carer or family member when they spoke with us, and some of them needed a carer to help communicate with us. And what we're doing now is we've collated all that data together, and that's what I'm going to tell you a bit about in a minute. And we're now co-designing ways of delivering care with those consumers and clinicians all in the one room to try and work out ways to do it that better meet the needs of both. So, what's been done by others to improve ED performance? This is just a review that we did internationally of strategies to improve ED performance. And they fall into two different areas. You either tend to do things that fix practices or processes. So, you might do something to improve triage, or you might put some technology into your system. Or they're things that involve team composition. So you might use nurse practitioners, or you might bring some mental health specialist into your ED or things like that. What we found though is that very often people only measure one or two things to see whether it works or not. And the problem is that things are often in opposition. So we know, for example, from other research that we've done, that safety in the ED and time to treat are in opposition. So if, for example, you think of safety strategies on a scale of 1 to 4, if you increase that safety by 1 point, you are taking an additional 18 minutes per patient to get people through that ED. So when everyone's saying, you've got to be safe, but you've got to get them through quickly, you can't really do both. And a lot of these processes and things were measured in terms of time to treat, or they were measured in terms of safety, and not recognising that there was a trade-off in both of those. So we also did some literature reviews internationally to see what strategies were available for our particular cohorts. No point reinventing the wheel, no one's got enough money to do that. So let's have a look and see what's out there already. What we found is there were a lot of diverse strategies out there, but very few of them were aligned with the ED purpose. So what do I mean by that? So if you look at government documents that say what should an ED be doing, you're meant to provide safe care, you're meant to provide timely care, and we already know those two are in opposition, and you're meant to provide a conduit to get in and out of the hospital. So anything that isn't one of those three things, the ED shouldn't be doing. And if you look at what you're doing in your own ED, you probably find that 30 to 40% of what you're doing does not address one of those three things. So a lot of the strategies were not aligned with the ED purpose. So an example would be for older adults, there was a detailed geriatric care within the ED, or trying to extend the geriatric care within the ED. Now that's not the purview of an ED, they should be sent somewhere else for that. There was also incomplete evaluation, which I talked about, and a lot of the interventions weren't systemic. So they addressed their own particular problem and didn't think about the whole system. And this often happens with interventions. The newest, greatest intervention sucks up all the resources and it looks really great, but it's sucking resources from other important areas, and other areas can suffer. So we did identify some promising interventions for adults, particularly about trying to transition them quickly or more quickly to alternate care, and some trauma-related management. In the mental health, the only thing that seemed to work from the evidence was consultation liaison psychiatry. Good luck getting that at the moment, especially in New South Wales. And for cultural and linguistically diverse, just tailoring action to particular communities, so very bespoke type of interventions. So this is what we found from our interviews. So looking at older adults, the two things that you really need to do, or we really need to do with older adults, is minimise the waiting times and address communication issues. Now, with older adults in the EDs we were working in, we saw older adults who were in the waiting room for 24 or 36 hours. So a 90-year-old sitting on a plastic chair for 36 hours is not going to improve their care. The EDs are not set up, and you'll know this yourself, they're not set up for the sort of nursing or care that manages everyday activities. So they're fine for urgent care, but they don't look after people who are there for 24 or 36 hours. So they don't look after things like their toileting needs and things like that. So a lot of the older adults actually decompensate where they're in the ED because they're not having that looked after. And we really need to try and transition them to this geriatric specific care more quickly, rather than holding them in the ED while we're trying to work out what's going on. The second one is about communication difficulties. A lot of older adults have difficulties because of cognitive impairment, even mild cognitive impairment. But they also have difficulties because they can't hear very well. Most older people, if they wear hearing aids, they'll remove them before they come to the ED because they're worried that they're going to lose them or they're going to fall out. So they often can't hear very well. And they're really polite, so they won't tell you they can't hear. So you'll be talking to them and they'll just be nodding and you'll think that they're understanding you and they're not hearing a word that you say. So it's very important to check that they've actually understood and to spend the time making sure that they've actually understood. We also need to consider the carer's needs. Often they come with an adult, daughter or son who's sort of with them, and we need to make sure that we look after them and we've got ways of looking after them as well. And we also need to think about addressing their safety and fears. So a lot of older adults are frail and they worry, and if they're even sitting in a bed where the person beside them is coming from the justice system and there's two police either side of them, that really, really worries. That can really worry an older adult because they feel very vulnerable and not safe. So, strategies for culturally and linguistically diverse patients. People say that CULD patients don't have good health literacy. It's not they don't have good health literacy, they don't have good health system literacy. A lot of them have better health literacy than you and I do. A lot of them are trained in, tertiary trained in many different professions, but they don't necessarily understand our health system. So they can come from places where the ED is the only entry. There's no general practice, there's no primary care. The ED is the only entry to care. So they can be used to coming from their home to the ED, even if they have something that we would go to primary care for, thinking that the ED is the right place to go. They also don't understand that the ED is not quick. So in some other countries in the world, they don't have the administrative process that we have that can turn a 10-minute ED appointment into a 3-hour appointment. So they have an expectation they're going to be treated very quickly. Sometimes, 10 minutes, 15 minutes. And if they're in pain, to them, that's an emergency. So a lot of it is managing expectations and helping them understand how our system works and what's going to happen to them. So in terms of that, the people that we talked to really wanted updated advice on things like wait times. They talked about it in terms of being like in an airport. They wanted to be able to hopefully check in from home, come in and then be notified, if the flight's being delayed or if the flight's being cancelled. They want to know about it. They want to know straight away. Now, a lot of our EDs are too scared to tell people. They think they're going to get angry and they're going to get violent. So we just say, yeah, we'll be with you in a minute or whatever. We really need to tell them. If it's going to be 3 hours for something, we need to tell them it's going to be 3 hours, and we need to tell them why. I mean, the moment they get some sort of scan or test, it's going to be 2 to 3 hours just to get the results back. It's important to tell them that and not just say, well, you'll just be here till we get your result back, because they'll be thinking 5 or 10 minutes. So update advice on wait times, and we need to provide information to them on demand. So if you're in New South Wales, and I'm assuming this is the same for other states across Australia, there is information available online on almost anything you can imagine to do with their ED care in their language. But it's not accessible and it's not easy to find. So at the moment we're working to try and have a one-stop where we can put a QR code up beside a little eye sign in the ED and have a link. So like similar to what you would get in a hotel, where you can select the service that you need or the information that you need and the language, and it will come up. But that information is actually there for you. It's just that you need to know where to find it. So we need to be able to provide them that sort of information. And we need to allow for cultural differences as well. So we find in our EDs that some cultures will have 50 family members come with them to the ED. So, and we need to think about how we're going to provide for that. Do we need a room for them, and so on and so forth. The other thing that we need to allow for cultural differences is in terms of language. So we use interpreters if we have a consent issue, but often if it's not a consent issue, we'll try and talk to them without the aid of an interpreter. Even with interpreters, there can be cultural issues. So for example, Arabic, we get an Arabic interpreter. If that Arabic interpreter is from the wrong culture, the person can be quite frightened that the culture is a culture that persecutes them back in the Middle East, and they won't trust that interpreter. But they'll all be speaking the same language, so you're not going to know that. So cultural issues in terms of interpreters are quite important. And it's important to understand, even for those who speak English quite well, that their cognition can suffer a lot just because of the fact that they're in pain or injured. So we've got a colleague in our team who she's been living in the US or Australia for 30 years. She's originally French, and her English is, I would say, impeccable. She had an accident a couple of weeks ago and ended up in the ED, and she said she lost her language, her English language, just because her cognitive capacity was reduced so much by the pain she was in. So even people who may seem to speak English or who are telling you, yes, I don't need an interpreter, I speak English, may have difficulty because of pain levels, and you may need to go slower to be able to communicate with them. So, and the last thing is provide advice on alternatives to ED. They may not know. They may not know that, with what the problem they're presenting with, they could see a GP or they could go to an urgent care centre. So disability patients, the EDs really are not set up well for disability patients. The EDs we work in, it's very difficult to fit people's personal wheelchairs in the actual waiting room, for example, and it's difficult within the ED itself as well. There's not a lot of room for them to move around. It's quite difficult. People with a disability end up in the ED more often than most because they often can't get to other health services either. So it's often not easy for them to get to a GP, for example, so they'll end up in the ED instead because they can call for an ambulance to get to the ED. So we need to think about providing mobility assistance where needed, especially in the waiting room. Things like toileting, for example, we need to provide a way for them to be able to get to and use the toilet. We've actually seen people in our observations where they just put a nappy on them. That's not dignified and appropriate for a person to have to sit there and soil a nappy and be sitting in that soiled nappy for 6 or 7 hours, which we've seen. We need to also address their safety and fears. Again, like the older adults, they do feel very vulnerable in the emergency department because often they can't move, they're stuck in their wheelchair, or sometimes they're moved from there to a seat, but then they can't move out of the seat, so they can't move around. And we need to address the carers' needs because most of them will come with a carer. We also need to provide systems for visually or hearing impaired adults. The EDs that we work at, they have braille, for example, outside the toilets that indicate, which toilet to go to, but there's none anywhere else in the ED. So how are they going to even find the toilet? So there's very little wayfinding or signage that's appropriate for people who have hearing or sight difficulties within an emergency department. And we could do that. It was quite good before COVID. It all got moved out during COVID because of infection issues. It's not been put back. There's a lot of people who are having a lot of difficulty because that's no longer there. And this is the last one I want to talk to you about, I think. Yep, the mental health patients. So a large majority of people who turn up to the ED with an acute mental health issue, and I'll put aside the drug and alcohol affected, but with just an acute mental health issue, they normally are highly anxious. And sitting them in a waiting room for 10, 12, 14 hours does nothing to alleviate that anxiety. They are also usually very tired. Most of them haven't been able to sleep for sometimes days. And all they really want is they want to be able to sit there and just have a nap, and that will help. And often that's just not possible. So the ED environment is really toxic to someone who has high anxiety. The lights are too bright, there's too much noise, there's too much activity, there's people running around and sometimes shouting and things like that. And there's no easy access to outdoors. If they could wait outdoors, they probably would alleviate some of their anxiety, but they can't do that because they're fearful that they'll then miss being called when it's time to see the doctor. So, and they're discouraged from smoking, for example, which sometimes that will help them alleviate anxiety as well. So we need to sort of try and address some of our environmental issues. Now, I know you can't rebuild your emergency department waiting room, but we could do things like maybe provide earplugs or masks or things that can just help dim down some of the external environment and stimulus that they're getting. So, so this is really just a snapshot. We haven't done the work with our Indigenous group yet. We're still working with them. It takes a little bit longer to work with the Indigenous populations. So I don't have any data for you from that one at the moment, but I do know that one of the things we really need to address with the Indigenous population is the do not waits. The ED is not culturally safe or not perceived as culturally safe, and often they don't want to be there, so they will leave as soon as possible. So that's really just a snapshot of some of the things that we're working on. But every day, all of our EDs are working at greater than 100% capacity. So the main issue really is the sheer number of patients in the ED. So we've seen waiting rooms with 90 people in it, which is just crazy given the size of the EDs. And it's really due to a combination of increased presentations. We're finding since COVID, where people didn't access healthcare, people are getting sicker, so they're more likely to present to the ED, but also access blocked to the hospital as well, where we can't get hospital beds for them. And what we saw in our observations is with busyness, the focus of the doctors and nurses is moving from providing care to process-oriented, so just ticking boxes and doing all these procedures. From the patient's viewpoint, the most important thing to them is the care aspect of it. So if possible, it's really important to try and be able to retain that ability to maintain care. Even with someone with a mental health condition, for example, just someone coming and checking on them and asking, are you okay, every couple of hours can do wonders to help alleviate their anxiety. So the other thing we found though is that each ED is very different. So this idea of having governments say, okay, this is something that you're going to do and let's roll it out across all the EDs does not work. Each of the EDs are very unique, and anything that you bring in needs to be tailored for that specific ED. So finally, I'd just like to thank my project team who are all up here. And if you'd like more information or to sort of keep tabs on what we're doing, there's a QR code there. We've got a website that will give you information. Thank you very much.
Thank you, Robyn. And we will have time for one question. Does anyone have a burning question they'd like to ask?
Nope.
Oh, no one's feeling great.
Charlie's going to do it.
Charlie's feeling great. Nice big voice.
Robyn, thank you for all your work.
Yeah.
I think pretty much everything that you've said there, most of us are aware of the problems. Who do you think you should direct this at to make change?
Oh, we already are directing it at. So, so we've got, see if I can go backwards here. Oh no, I think we've gone on it, yeah.